Hello, and welcome to the Grand Rounds for the Minnesota Regional Spinal Cord Injury Model System, or MIN-SCIMS for short. Thank you all for joining us today. MIN-SCIMS is funded by the National Institute on Disability Independent Living and Rehabilitation Research to support innovative projects and research in the delivery, demonstration, and evaluation of medical, rehabilitation, vocational, and other services to meet the needs of individuals with spinal cord injury. Next slide. MIN-SCIMS represents an exciting partnership among the following Minnesota institutions: Courage Kenny Rehabilitation Institute in Minneapolis, Mayo Clinic in Rochester, Regions Hospital in St. Paul, and the University of Minnesota in Minneapolis. Next slide. Our community collaborators include the Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up, Stand Up to Cure Paralysis, Paralyzed Veterans of America, United Spinal Association, and the North American Spinal Cord Injury Consortium. This system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency medical, acute care, acute rehabilitation, and post-acute services. My name is Amanda Herman, and I will be the moderator of today's session. I'm a research associate at the Health Partners Neuroscience Center and part of the MIN-SCIMS. Next slide. A few housekeeping notes. The University of Minnesota has organized the CME for today's webinar. Please see the chat for information on how to record your attendance and claim CME credit for attending this webinar within 24 hours of the event. The meeting is being recorded and will be posted on the MIN-SCIMS website. To earn CME credit for today's presentation, please click on the link in the chat. Due to the number of registrants for today's webinar, we have placed the phone lines on mute to reduce audio feedback. However, we welcome and encourage audience participation using the Q&A function. If you have technical or logistical questions, we ask that you please submit those into the chat to Dan Kelly. And we extend a huge thanks to those who work behind the scenes to make these webinars possible. Next slide. The title of today's presentation is Overview and Current State of the Minnesota Regional SCIMS. The speakers for today's webinar are Drs. Leslie Morse, Kimberley Monden, and Ricardo Battaglino. Dr. Morse is the chair and professor of the rehabilitation medicine at the University of Minnesota Medical School and has 16 years of experience in SCI clinical care and research. She has extensive experience directing NIDLR SCIMS as the former project director of the Spalding Harvard SCIMS and the former co-project director of the Rocky Mountain Regional Spinal Injury System. She also serves as the co-chair of the Model System Knowledge Translation Committee. Dr. Monden is an assistant professor and licensed psychologist in the Department of Rehabilitation Medicine at the University of Minnesota Medical School and has 12 years of experience in SCI clinical care and research. She studies resilience and appraisals of injustice with a specific interest in improving quality of life and long-term psychosocial outcomes after SCI. Dr. Monden has research funding from NIDLR, the Department of Defense, and the Craig Nielsen Foundation. She also serves as a co-project director of the MIN-SCIMS and is the principal investigator of the modular project, is meeting the SCI physical activity guidelines associated with health-related and psychosocial outcomes. Dr. Battaglino is a professor and vice chair of research in the Department of Rehabilitation Medicine at the University of Minnesota Medical School. Together with Dr. Morse, he established and co-directs the Rehabilitation Medicine Translational Research Laboratory. He is an internationally recognized molecular biologist and an expert in bone biology and gene and biomarker discovery. He has worked for more than 15 years in animal models of SCI, as well as cohort-based studies in SCI. He also serves as the director of research for the MIN-SCIMS and the principal investigator of the site-specific study, Briviac to reduce neuropathic pain in chronic SCI, a randomized double-blinded placebo-controlled clinical trial. Welcome and thank you all for presenting. Next slide.
Thank you for the introduction. Amanda, do you want me to pick it up from here?
Yes, please. Thank you.
All right, wonderful. Thank you for the introduction. I'm going to give an overview of model systems at a very high level and talk a little bit about some of our database contributions and our progress to date. And then I will turn it over to Ricardo, who will talk about our site-specific project. And then Kim will talk about our modular project and progress on that project to date. And then we will open it up for questions and discussion. And just wanted to highlight funding of various investigators, and actually regenerative medicine funding was left off from this list for Dr. Battaglino. Next slide. Okay, next slide. So SCI model system centers are funded by the National Institute of Disability, Independent Living and Rehabilitation Research. They're awarded on a 5-year cycle, and each 5 years, the entire model systems is recompeted. And so we tend to see a fair amount of turnover every 5 years. There are currently 18 funded SCI model system centers, and each center is expected to contribute to the National Spinal Cord Injury database that is managed by the Statistical Center that's currently housed at UAB. Next slide. This is a map of the currently funded 18 model system centers. This was recompeted 1 year ago. So we have been an established model system center for 1 year now. And due to efforts at the national level, additional funding was earmarked to bring in 4 additional centers after the first 14 were funded, and those 4 centers came online about a year after the initial 14. So we're currently up to 18 centers nationally. You can see from the map, they're meant to be regional, though there is more representation on the coasts, and in my opinion, a lot of need to increase representation in the Midwest. Next slide. So brief history. Model systems were established in 1973, and funding was initially allocated through the Department of Education, and that then moved over to Department of Health and Human Services. And their model system funding was earmarked for complex conditions that require integration of state-of-the-art medical care from the time of injury to the time of death. And there was an understanding that there was a need to integrate research into the continuum of care for these very complex conditions. And so there was an understanding that some of the expertise was centralized, and that there was a charge and a desire to mandate or at least facilitate the sharing of information from centers of excellence to other centers within a regional catchment area. And so that led to kind of the 3 pillars of model systems, centers of excellence activities, a state-of-the-art system of care from the time of injury to community integration, and ideally staying in touch with an individual and through the lifespan, a strong integrated research portfolio, and then a system to disseminate and educate across all of stakeholders, stakeholder groups within a geographic area. So historically, 32 centers have been federally funded and have contributed data. Those are not the same, obviously, 32 centers that have been funded continuously. So there's a little bit of entry and then exiting of this pool. Once a center is funded, there's an expectation to continue to contribute to the national database for as long as a center is able to do that. And there's a small amount of funding that is allocated each cycle for unfunded centers to continue as a data contribution center. So as of June 2022, the database contained information on 51,000 unique cases, and this is It's estimated that the model systems captures around 6% of the new spinal cord injury cases in the US in total. It's the world's largest and longest active SCI research database and the most extensive resource of available information about the characteristics and life course of individuals with SCI. So we have the national database link here for those who are interested in learning more about the national database. And because this is funded through federal funds, all of the data that are collected are publicly available for analysis in a de-identified data set. And you can download a data set on the UAB website. Next slide. So the Model Systems Knowledge Translation Center is also recompeted every 5 years. This is in addition to the national database. So these three funding opportunities all occur at the same time, and the Model Systems Knowledge Translation Center works obviously very closely with each of the 18 funded model system centers and with the database. And as the name suggests, the Knowledge Translation Center is really charged with curating and making publicly available a multitude of pieces of information that can be used either for disseminating research findings, patient handouts, patient education handouts. There are videos, webinars. So this body is really responsible for helping to translate and get information that is generated from the collaborative efforts from all of the model system centers, the 32 centers who have been funded in the past, who are funded currently, and who continue to contribute to the national database. Next slide. Next slide. So as I mentioned, there are fact sheets, slideshows, quick reviews, which are a summary of findings from research projects that have been funded by model system centers, hot topics, which are a really focused deep dive into an area of interest. And there's typically a hot topic each 5-year cycle, and an archiving of videos that can be shared broadly. Next slide. Next slide. I just wanted to highlight some of the resources that are available through the MSKTC website as it pertains to exercise and fitness after spinal cord injury, as this is a particular interest of our Model System Center, as well as the topic of our modular project. Next slide. I wanted to talk a little bit about the governance of our regional model system center. This has changed and evolved a bit since we initially conceptualized how we would run our model systems to how we actually implemented governance of this. And so I would say this model has evolved a bit over the past year. But our model system, again, our model system center is composed of a collaboration of the 4 institutions that cross healthcare systems to collaborate in this space. And our system is led by an executive committee with representation from each of the 4 centers and our community advisory board. And the executive committee meets once a month. And then the entire system-wide model system meets once a month as well. And then we have 4 committees that meet, some regularly and some on an as-needed basis. So the arbitration or conflict resolution committee was established to help mitigate or resolve problems that might arise, either amongst colleagues within one institution or across the 4 centers. And fortunately, we have not had any conflicts that have needed to be elevated to the arbitration committee, but that committee is impaneled and ready to assist with any issues that arise. We have a clinical care committee that is currently led by Dr. Reeves from Mayo, and that committee meets regularly to identify various projects related to enhancing and standardizing care activities and disseminating that information both within our center and to our catchment area. Communications Committee is responsible for, amongst other activities, putting together this Grand Round series, and I'd like to acknowledge the wonderful job that this committee has done in implementing that. And then our Community Advisory Board. Next slide. So there are four main activities that we engage in on a regular basis. Database contributions. We have a site-specific project that Ricardo will talk about. Our modular project contributions. I'll give you an overview of the modular projects in a minute, and then Kim will talk specifically about the modular project that we're leading, and then our dissemination and education activities. So database contributions. To be a model system center, there has to be adequate exposure to individuals with traumatic spinal cord injury. And there's an expectation from our funding agency that we contribute at least 30 cases of traumatic spinal cord injury a year to the national database. So I like to share the information that the MSKTC and all of the resources that the MSKTC pulls together, because that's really the foundation of how the national database contributions are being used to help advance and standardize clinical care, identify research opportunities, areas for focused need in terms of research funding and future projects that could or need to be conducted to advance care. So again, all of the database contributions that we collectively make form the foundation for these resources. So we're expected to enroll at least 30 cases per year, and we're expected to enroll 80% of those who are eligible across our 4 collaborating centers into the national database. And so the funding cycle for this grant ends in September. And so we've done very well. As you can see, we've enrolled 55 individuals into the national database, with Courage Kenny currently contributing 47% of our system-wide volume, Mayo contributing 22%, Regents 27%, and the University of Minnesota 4% of our traumatic SCI volume. Next slide. Modular projects are also mandated by our funding agency, by NIDLR. It is a way to enhance and advance collaboration across the 18 centers. So one of the reasons that we have model system centers is to facilitate collaboration across these centers of excellence in a way that will elevate our capacity as a field to conduct greatly needed research that will impact outcomes. So modular projects are mandated. Each center has to contribute to, I believe, at least one modular project. Kim, 1 or 2? I think we have to contribute to at least one modular project.
Yeah, I think it's us, and then maybe it's 2. Maybe it's a total of 3. I can't remember.
So as you can see, we have 4, 5, 6, 7, 8, 9. We're currently collaborating with 9 centers. So 9 center projects. We're leading 1 and then collaborating in 8 additional modular projects nationally. These modular projects tend to be less resource intensive than our site-specific project. They tend to be either survey-based or data collection that can occur during national database collection time points. So we are collaborating broadly, and I think it's our collective goal to be recognized as strong national collaborators in a variety of potential projects. So next slide. Okay, I'm going to hand it off to Ricardo to talk about our site-specific project.
Well, thank you, Leslie, and thank you, Amanda, for the introduction. For the next 10, 15 minutes or so, we're going to talk about the progress on our site-specific project, which is BIVRIAC to reduce neuropathic pain in chronic SCI. Is a randomized, double-blind, placebo-controlled clinical trial. Next slide, please. So just in numbers, prevalence of neuropathic pain affects anywhere between 40 and 67% of Americans living with spinal cord injury at some point will experience debilitated neuropathic pain that will interfere with rehabilitation efforts and quality of life. And in many cases, it will be refractory, resistant to pharmacological treatment. Next slide, please. So we had many testimonies like this. Somebody saying, in this case, Sherry from our own SCI area, the experience of living with severe neuropathic pain has been described as chronic, debilitating, and depressing, at times leaving me hopeless and nearing the end of my will to live. Next, please. So this is clearly a very serious problem, and there are not many treatments that have shown efficacy to treat it. So this is when we actually, we were at Craig Hospital, and we end up meeting Scott Falchi, who is a neurosurgeon that performs this dorsal root entry zone DRESS lesioning surgery. Next, please. I mean, you can. So DRESS surgery is a microcoagulation surgery that has been applied in cases of severe sublesional neuropathic pain that is refractory to medications. And this is done by very few neurosurgical practices nationally. And again, we were lucky enough to be in Englewood, Colorado, next to a Swedish hospital where Scott Falchi was doing this. And one of the things that needs to be noticed is that there are excellent surgical outcomes when it comes to including or eliminating or reducing dramatically neuropathic pain. However, this is an extremely invasive procedure because it involves removal of tissue that in most of the cases, we would like to leave intact for the situation where we may be able to do some form of rehabilitation or regeneration. Next. So Scott Falchi performed using some of these surgical histological samples. He performed a proteomic analysis, which is a way of looking for every protein that is expressed. And he was essentially looking for a diagnostic biomarker of neuropathic pain. So he isolated electrically hyperactive and normal substantia gelatinosa, and he performed a soma scan screening. Next. And he came up with a number of proteins that were elevated and that were diagnostic for severe neuropathic pain. And one of them is this protein called SV2A that was extremely elevated in samples of hyperactive substantia gelatinosa. Next, please. So SV2A is a protein that has been known already for some time, and that is implicated in models of partial and generalized epilepsy. Now, the FDA has approved a number of years ago drugs that treat this drug, and one of them is BIVRIAC. And the drugs, therefore, is being proven safe and effective for the treatment of partial onset seizures in persons that suffer epilepsy. Now, there are different drugs that combine SV2A, BIVRIAC being one of the latest generation ones, Keppra is another one. The advantage of Briviac over Keppra in this case is that it has a binding affinity at least 30 times greater. So it can be used at lower doses to achieve the same effect. Next, please. Now, originally, Scott Falchi performed, he prescribed this drug to 5 selected individuals with severe pain. And so he obtained consent and performed compassionate use of the drug. And he was very encouraged when he actually observed that there was significant reduction in pain in all the patients that had undergone this. So at that point, next please, we started working on what it became the predecessor of our current project, which is a pilot clinical study that we started when we were still at Cray Hospital. And the aims of the study was to determine whether a 3-month course of daily Briviac reduces severe below neuropathic pain in SCI. And then that was a primary goal. And then there were 2 exploratory aims. One was to determine whether the 3-month course of daily Briviac could increase parietal operculum brain connectivity, which is an area of brain connectivity that is associated with pain and with pain. And finally, there was a third aim that was to determine whether baseline microRNA 485, which is a type of microRNA, we'll talk about that later, was also associated and could be in some way used as a prognostic or even a predictive marker of Briviac treatment efficacy. Next, please. So the design is, as we said, is a randomized, double-blinded placebo drug, and it's it was 10 participants with severe neuropathic pain, and it's a 3-course month of Briviac. Next, please. So these are inclusion and exclusion criteria. So we're looking for adult individuals, community dwelling, with neuropathic pain that was on the average over 3, and that had failed to achieve pain relief with any other medications. And there were some exclusion criteria too, especially dealing with the use of any other investigational drug 30 days prior to the enrollment to the study, currently pregnant, active epilepsy, which is something that we wanted to avoid, and a history of malabsorptions of other GI diseases that may have influenced absorption of the Briviac. Next, please. So the primary outcomes are reduction in pain intensity, and we consider a clinically meaningful reduction in brief pain inventory of 1 point or more as a definition of drug response. And secondary outcomes, again, changes in mood, satisfaction with life, community integration, brain resting state, functional connectivity, and changes in microRNA 485. Next, please. So this is some of the pilot studies results. So I'm going to focus on these 2. We are confirming pretty much the original results obtained by Scott Falchi now in the context of control pilot clinical trial, and we are measuring in this case DN4, which is a specific measure specific to neuropathic pain. And at this point, we haven't even unblinded the groups. We have reasons to believe that group B is a drug group, and there is a significant reduction of at least 1.7 points in the DN4 scale, where there is no changes in pain in the individuals belonging to group B. We are also doing a different kind of analysis. These individuals are taking the drug twice a day. So we are also interested in measuring for each individual the worst pain. And we're also taking worst, medium, average, and low pain. And as we can see, individual number 3003, which belongs to group B, is reporting significantly lower values day by day compared to individual 3005, which is in the placebo or in the A group, which we suspect is a placebo group. Next, please. We have some preliminary results that indicate that there are changes in connectivity to key brain areas involved in pain and attention, the amygdala and the insula. So on the left-hand side panel, we see that treatment of group B led to an increase in left amygdala to medial precentral resting state connectivity. And in the right panel, we see that there is a decrease in the B group in bilateral insula to bilateral supplementary motor cortex resting state connectivity. So these two changes are consistent with changes induced by the drug treatment that have to do with regions of the brain or with connectivity between regions of the brain that are related to pain and attention. Next, please. Just 2 words about microRNA. MicroRNAs are short, non-coding, single-stranded molecules of RNA that have emerged as important biomarkers and molecular mediators. So these are small chemicals that circulate in blood, and that can give us an indication of the status of different physiological processes at any given point. So we think that we may use them as diagnostic biomarker for conditions or prognostic biomarkers to predict how somebody's going to react, for instance, to a drug treatment. Next, please. We had originally done a microRNA genome-wide screen, and we found out that this microRNA 485 was actually differentially expressed in acute, chronic, and in individuals with no SCI. So why we are interested in this one? Because these microRNAs have the ability to regulate expression of proteins. And this one, 485, specifically targets SV2A. So we reason if we can predict indirectly via the expression of 485 what's happening with SV2A, SV2A being the target of our drug, we may be able to use 485 as a proxy for SV2A and predict individuals that are going to be higher, more or less responsive to the drug just by looking at a measure of 488 in circulation. Next, please. Oh, I'm done here. So anyways, thanks a lot. I'll take questions at the end of the meeting, and Kim, your turn.
Thank you, Ricardo. And thank you again, Amanda, for the introduction today. And I'm going to be talking about our module project. So that's the one that Leslie mentioned, where we go to project directors meeting in DC at the beginning of the grant cycle, and all of the model systems propose module projects, and you have to have at least, I think, 2 other centers sign on to your project for your project to move forward. So we proposed this project about meeting the physical activity guidelines for individuals with spinal cord injury and whether or not meeting the guidelines is associated with health-related and psychosocial outcomes. So as a little bit of a background, we know that increasing physical activity is essential for health and quality of life, not only for individuals without spinal cord injury, but also for those with spinal cord injury. And that physical inactivity leads to many secondary health conditions, such as cardiovascular disease, type 2 diabetes, autonomic nervous system dysfunction. We know that physical inactivity is associated with increased depression and pain, more fatigue, and oftentimes poor quality of life. And also obesity, cardiovascular disease, and diabetes are 2 to 4 times higher for people with spinal cord injury compared to the general population. So again, another reason why targeting physical activity in this population is so important. So in 2011, and then also in 2018, the guidelines were revised. A Canadian group, Kathleen Martin-Guinness and colleagues, developed the spinal cord injury physical activity guidelines, So they were initially published in 2011. Like I mentioned, they were revised in 2018. And they were more focused on physical fitness and cardiometabolic health in adults with spinal cord injury. And to date, no study has demonstrated the health benefits of meeting the spinal cord injury physical activity guidelines versus not meeting the guidelines. And so these are the scientific guidelines that were published, I think it was in Spinal Cord or JSCM, I can't remember. But they essentially say that for cardiorespiratory fitness and muscle strength benefits, adults with SCI should engage in at least 20 minutes of moderate to vigorous aerobic activity 2 times a week, and 3 sets of strength training 2 times a week. And for cardiometabolic health, individuals with SCI should engage in 30 minutes of moderate to vigorous intensity aerobic exercise 3 times a week. So that's 90 minutes total a week, which is lower than that of the general population, which is 150 minutes per week of moderate to vigorous intensity aerobic activity. And so the purpose of this study is to use the model systems longitudinal follow-up database, which provides an ideal setting to address our research problems. So we proposed a module study with the primary goal of determining whether meeting the guidelines is associated with improved health and psychosocial outcomes. And the study is cross-sectional in nature, but we believe the findings from the study will be used in the future to design clinical trials testing the health benefits of meeting the spinal cord injury physical activity guidelines. We have 3 aims. So we want to determine if meeting the physical activity guideline for cardiometabolic health, so that's the 90 minutes a week of moderate to vigorous activity, is associated with positive health outcomes, positive psychosocial outcomes, and greater social and occupational integration. So for aim 1, we want to determine if meeting the physical activity guidelines for cardiometabolic health is associated with positive health-related outcomes. So we're going to use the Leisure Time Physical Activity Questionnaire, or the LTPAC, to determine the percentage of participants who meet the physical activity guidelines. And then we'll also assess differences in rehospitalization, which is our primary outcome, in the prior year, which we will get from our Form 2 follow-up data, and also self-perceived health status, which is our secondary outcome, which also comes from Form 2, based on meeting or not meeting the guidelines. And then in this analysis, we'll also consider demographic, injury, medical comorbidities, and motivational characteristics, things like resilience, as covariates in the analysis using Form 2 data collection. So the only thing we're really adding to Form 2 data collection are the Leisure Time Physical Activity Questionnaire, the Para-SCI, which is a 3-day recall, and then we have some other questions about like structured exercise, group exercise. And then we also wanted to gather a little bit information about how many people were using wearable devices and whether they were providing the information to us using their wearable or not using their wearable device. The second aim is to determine if meeting the guideline is associated with positive psychosocial outcomes. So here we're going to assess differences in pain, mood, and quality of life. And again, those are all included in Form 2. And again, we're going to look at the demographic, injury, and other personal characteristics like resilience as covariates in this analysis. And for aim 3, we're going to determine if meeting the guidelines is associated with greater social and occupational integration. And we will use the chart, which is the chart SF, which is included in Form 2 as well. And again, using those same covariates. So as I mentioned, all outcomes are derived from Form 2. So the independent variable meeting the physical activity guidelines or not is derived from the Leisure Time Physical Activity Questionnaire, or the LTPAC. This module adds about 30 minutes to Form 2 data collection, and we're aiming for a total of 350 participants. These are all of our participating centers. So there's us, obviously, the National Capital Spinal Cord Injury Model System, or MedStar, the Northeast Ohio, which is Case Western, University of Pittsburgh. We have South Florida, so Miami, and then the Michigan Spinal Cord Injury Model System, and they were one of those new 4 centers that Leslie mentioned. So they joined a little later in the cycle and then joined on to our module recently. As far as our progress to date, we had a little bit of a delayed start because we were using a single IRB. And as we have all learned through this process, it adds a significant amount of time to start up. So the University of Minnesota's IRB is serving as the IRB of record. And that was determined in May of 2022. And then most sites were approved, IRB approved in December 2022. And we're still waiting for Miami and Michigan to receive IRB approval. So Michigan signed on late and Miami has had some delays due to some circumstances at their site. And then so far to date, we've enrolled 6 of our 350 participants. 5 of those participants have come from MedStar and 1 has come from Case Western. We've had 1 Form 2 follow-up so far in the Minnesota Regional Spinal Cord Injury Model System. And unfortunately, that participant declined to participate in this module. So that's where we are with the module to date. And at this point, I think we're gonna open it up to any questions.
Thank you all for an excellent presentation. We now invite you to type questions into the Q&A box. So go ahead and type any questions in that you have. And we'll wait just a couple minutes here to see what comes through. So while we're waiting, Kim, I know you mentioned the Form 2 data collection. And I think, could you just talk a little bit about the timeline for data collection? So how we collect, on admission to rehab, and then we're collecting at a year, and what kind of that Form 2 means.
Sorry, I forget about the jargon. So Form 1 is our baseline data. Essentially, it's when people are admitted to inpatient rehabilitation. Form 1 is the model systems term for that. We collect just a lot of medical history, ASIA scores, and then not all of the outcomes that we have in Form 2, but some of them. So things like depression, pain. I can't think of everything that's in Form 1 off the top of my head. And then we do Form 2, which is 1 year post-injury, then 5 years post-injury, and then every 5 years thereafter. And that is a longer assessment than Form 1, where we look at all sorts of things like pain and depression and community integration and perceived health status and comorbidities and a lot of things I'm probably forgetting. Leslie, can you think of any others that are in? There's like resilience with the SciQual resilience.
Rehospitalization and secondary complications. So a long-term longitudinal assessment of health problems that arise over the course of injury, change in sociodemographic characteristics, so marital status, education, that's updated every 5 years.
Great. Well, I don't see any questions yet, but would one of you want to just briefly mention the non-traumatic pilot as well?
I was actually thinking about that as we were going through. So do you want to go, Leslie?
Sure. There is, so historically, and through present time, the national database is focused on traumatic. So to be eligible for the national database contributions, an individual has to have a traumatic spinal cord injury. There is a growing interest in also expanding expertise across model system centers to non-traumatic. And so non-traumatic injury and including non-traumatic cases into the national database. There has never been consensus on how a non-traumatic spinal cord injury case is defined. And so or what the important characteristics to add to the national database are. And so this pilot, there's some small amount of supplemental funding from NIDLR to begin these discussions around how do we define non-traumatic spinal cord injury? How would we change the data collection forms to allow that? And so the first step, it has been to get a sense of how many cases of non-traumatic injury are coming through each of the centers annually, and how to begin to conceptualize data collection. So that's where we are now. We're beginning to identify cases and collect some pilot data for this effort. So it is possible that in the next cycle, the national database contributions could be both traumatic and non-traumatic.
And a lot of the modules were encouraged to include non-traumatic cases as well as traumatic cases. So like one that we're participating in on bowel and bladder management, bowel management through Case Western, like they're including non-traumatic injuries in their sample, which has posed a lot of the questions that Leslie has brought up in determining, they said we don't want anyone with progressive. Well, it's really hard to find a non-traumatic injury that didn't progress in some form. So, and then what is the date of injury? Is it the date that someone first presented to the emergency room, or the date they were first admitted? So there's all sorts of interesting questions that come up when we start looking at the non-traumatic cases.
Great, thank you. All right, well, I don't see any questions that have come through, so a quiet bunch today. If you want to, I guess one just came through, so let's answer this one and then I'll move to the next slide. All right, so Sophia Bowens has a question. So she's an acupuncturist at Health Partners, and she specializes in neural conditions. Thanks for the presentation. She's wondering if you've ever considered acupuncture as a therapy for spinal cord injury patients, and she'd love to connect with anyone who might have interest in learning about that.
That's wonderful, Sophia. Thank you for the information. I wonder if maybe connecting with the clinical care committee might be a good place to start. Maybe considering if you'd like to give grand rounds on how that might be applicable to spinal cord injury. That'd be great.
Great, sounds good. Okay, we'll go ahead and move to the next slide, please. Thank you. All right, okay. And Sophia, I'll connect with you after. All right, great. So thank you all for attending today's grand rounds. We apologize if not all questions were answered. Please feel free to reach out to the presenters directly if you'd like to follow up with any questions that you have. The recording for this webinar will be posted soon on the SCIMS website, and that'll have a link to our YouTube channel where all of the previous grand rounds are. As a reminder, please see the chat for information on how to obtain CME credit for attending today's webinar within 24 hours. At the end of the webinar, there will be a brief 3-question survey that will pop up. We'd appreciate your feedback. We'd also hope that you can join us for our next grand rounds on Thursday, April 6th at noon Central Time, where Dr. Michael Stillman and Dr. Nethra Ankim will present one institution's efforts to address disability-specific medical education. Thank you all and have a great rest of your day.